The first thing you'll notice is that the patient is positioned in the supine position, head a little bit elevated, not much different than the position they'd be in when you came to the bedside. We have the arm position abducted at the shoulder, flexed about 90 degrees at the elbow, mainly just to open up the space to put the probe up high in the axilla. So you can see we're up high in the axilla, as high as really you can go before the tissue starts to get deeper, before the shoulder muscles essentially allow you a less superficial needle pass. If you get more proximally along the nerves, more medially, anatomically, you're going to be going more and more towards an infraclavicular block. The advantage of this axillary block is that we're at the more superficial location where the nerves are more superficial and the needle insertion is able to be done in a more flat trajectory. So you can see this probe position from another angle here. You can see again, if I get a little more proximal, it's much more muscular up there, so it's not going to be as easy of a view because the nerves will be much deeper and the needle pass is going to require a lot steeper needle angle of insertion. So we'll go ahead and take a look at the ultrasound image now. First thing you'll notice on the left side of the screen, this is the side the needle is going to be coming from. This is lateral anatomically. Right side of the screen is medial. Middle of the screen you can see the pulsatile axillary artery. If I relax the pressure on my probe, see a few veins that are able to be visualized only after relaxing the probe. Compress them, they're no longer visualizable. Similarly, deep and a little bit lateral to that artery, you can see another vein, it looks like, that's visible there. You can confirm vein from artery by the compressibility and the pulsatility, but you can also confirm vein and artery by using color flow. So we'll go ahead and turn color flow on. There we go. Go ahead and leave that there. This gives you a nice pulsatile arterial flow there. Notice that deep to that artery does not look to be much flow at all, so it's hard to say whether that's truly vein. It's not fully compressible there. If it is flow, if it is a vessel, it's a vein. So I'll try to avoid that black at the 8 o'clock position relative to the artery, just in case that is a vein, but certainly no significant flow. We'll go ahead and move that a little bit more superficially, the color flow. Push it up and go up a little bit higher. There you go. You can also see that there is some venous flow. Pretty consistent with venous flow, just sort of steady flow, non-pulsatile. If anything, there's jugular venous pulsations. So just a couple of conformational tools to tell where the vessels are and what type of vessels they are, artery from vein. In terms of identifying the target nerves, there's 4 nerves in question. First is the most, jumps out the most at you on the screen. That's the musculocutaneous. That lies right below, between the biceps muscle and the coracobrachialis muscle. And if I adjust my tilt slightly on my angle of my ultrasound, just deep to the artery, and it looks like a little bit past the artery is going to be the radial nerve. And in kind of a honeycomb looking appearance, just superficial to the artery at about the noon position, looks like that's going to be our median nerve. And then just medial to the artery in its classic location, just under those hidden veins, is the ulnar nerve. Now our plan is not necessarily to stimulate these nerves. Our plan is just to encircle musculocutaneous with about 5 cc's and then encircle the artery. And we'll try to target the median, the ulnar, and the radial nerves with our needle, but we won't necessarily try to stimulate those. As long as we get local anesthetic around each of those nerve components that we're visualizing, it's not so critical that we stimulate them. In fact, it can be a little bit distracting at times. So we actually do have our stimulator on, as you can hear in the background, but we're leaving it at 0.2 milliamps. The reason for that is simply that at 0.2, we're trying to always avoid a nerve twitch. If we get a nerve twitch at 0.2, it would be highly indicative that we're intraneural. So even if you're not using nerve stimulation like we're currently not using now for this block, even if you're not using it to try to get a twitch, you can use it in reverse and try to avoid a twitch as one additional safety measure to avoid intraneural injection. Excuse me, we'll get started by cleaning the left side of the probe here, the lateral side where the needle insertion is going to be coming from. I'm going to give a little skin wheel. Now notice, skin wheel, a little bee sting here, sir. Skin wheel is fairly close to the probe with this one because the target's so superficial that you don't really benefit. A lot of the blocks that we do, you don't really benefit from inserting farther from the probe with this one because you do a lot of needle redirecting. So typically we'll insert a lot farther from the probe, but for this one, since it's so superficial, we actually insert a little bit closer. Okay, the first target is going to be the musculocutaneous nerve. You see my echogenic Pionk needle coming in just under that musculocutaneous nerve. I'm going to go ahead and give 1 cc there. Go ahead and give another one. Okay, we're giving 2 deep to the nerve. And I'll slowly give 3, and I'll pull back and flip over the top of the nerve. Go ahead and give 3. I'll give 1 more there, please. Okay, you can see a nice push down on that musculocutaneous nerve. So we gave a total of 6 below and above the musculocutaneous nerve. Now what I'll do is I'll flatten out my needle angle. I'm going to hydrodissect my way just under that artery. We'll dissect under the artery and advance to the radial nerve. Aspirate and give 5 cc's there, please. You can see the artery popped up there. Okay, we've got 11 total cc's. Now we've just dissected the entire underbelly of that artery there. You can see the radial nerve is much more apparent now, kind of a wide sausage shape at about the 4 o'clock position relative to the artery. Okay, we'll pull back and now go above the artery to about that 12 o'clock position. And we'll do another slow 5 cc injection. I'll hydrodissect that median nerve off the artery. On 3, 1, 2, 3, inject. Aspirate and inject. Okay, we've given 16 total. Now working our needle. Just past the artery. We'll give another 5 cc slowly as we advance towards the ulnar. Okay, so you can see we're pushing the ulnar nerve up, which provides a nice black contrast underneath the white nerve. Okay, now we're going to pull back and go over the median nerve. We'll just delicately work our way over the top. 1 cc increments. Go ahead and give 1 cc there, please. Another 1, please. Another 1. Another 1. 25 total. And so for the last little bit, we've now gone above and below median. For our last 5 cc's with a 30 cc total. I'm going to slowly inject, aspirate and inject, and I'll hydrodissect over the top of ulnar. See ulnar now pushing down. Just to point out all 4 of those nerves that we just injected around after the fact now, since they're a little bit better contrasted now. So you can see musculocutaneous here. There's the axillary artery. You can see just deepen past it, just deepen medial to it, the radial nerve. You can see just superficial to the axillary artery is the median nerve here. And then just past the artery, which we injected below and above, is the ulnar nerve. And we're done with the axillary brachial plexus component. We'll go ahead and freeze that image. Just to be sure that we can get the intercostobrachial and medial brachiocutaneous territories of the, specifically the elbow, if they're working in this area at all, we'll just do a little ring block of 1% lidocaine, just to ensure that we can get some surgical anesthesia there, since this patient will not have a laryngeal mask airway placed during the case. They'll have a deep propofol sedative, but just to be safe, we'll infiltrate that region. And we've just got 1% lidocaine pulled up. And you can usually accomplish this with about 10 cc's of 1% lidocaine. Okay, this is going to be a bee sting here, okay? We'll start in the axilla, big pinch, and we'll just hydrodissect the soft tissue plane here. You can see kind of a sausage appearance subcutaneously as I aspirate and inject that plane. Okay, we've made one pass there with about 5 to 7 cc's or so. We'll inject now, insert now, just before the edge of where we previously injected subcutaneously, so that part is numb that we're inserting through. And we'll subcutaneously inject and advance another 5 cc's or so subcutaneously. For the last couple cc's, again, sub-Q insertion through the area that was previously numb.